A very good evening to all of you. Namaskar, Vanakkam, Sastriyakal, Assalamu Alaikum from my side. This is Dr. Vivek Goyal, and I am again very glad to be present with you for yet another class of internal medicine, and we shall again discuss nephrology with you. We've already had two very interesting and very engrossing classes of nephrology. So much so that I have even, surpassed the time that was allotted to me by quite a margin, creating quite a stir among the students. But, and I shall try to leave you by the time I left you all yesterday. So, yes, hello, good evening in all the languages probably which I know came to Majama and all the languages, ki haal hai, fe kaise ho, and all the rest of the languages also, which probably I am not that acquainted with, but I mean from the bottom of my heart, good health to you and a very warm greetings to you right at the onset of my class. Okay, so let us begin with the very mandatory, how's the Josh? Very high, sir. How's the Josh? Superbly high, sir. How's the Josh? Very high, sir. So this is the way we shall start today's class. Now, as we have a very good motivation we've been having since the beginning of every class, I should like to open today's class by propagating the virtue of gratefulness, by propagating the virtue of thank you, because we must be thankful for whatever we have, and we'll end up having more. If we only concentrate on what we don't have, we will never have enough. So right at the onset, I request you all to just take a pause for a couple of seconds in your own mind, in your own heart, and thank the Almighty, thank to the Supreme Power, in whichever form you might do so, for the first and foremost, your existence today. Thank Him that you are there with all your might, with all your breath, with all your atria and ventricle pumping, with all your neurons discharging the electric current today. Because trust me, there have been many who did not even wake up today, or who are not even alive at 7:32 p.m. right now. So we must all thank the Lord for a wonderful day, and more so for a wonderful opportunity to be able to study medicine, and for having got the opportunity to contribute to the society in the form of a doctor. Nothing could have been better. And trust me, you are living the dreams of not less than maybe billions of people. Okay? Now, just a second. I shall just adjust my chat box, so you know. Yeah. And of course, the famous saying of the best and the greatest Swami Vivekananda, take risks in your own life. If you win, you will lead. If you lose, you can guide. So never be afraid to take the risk. It's also a saying that if you're not living on the edge, you're not living enough. So risk to Spider-Man ko bhi lena padta hai, boss. So why are you afraid to push your limits? Take considerable and calculative risks, because if you just play safe, if you just want to be on the shores and look at the sea and think what it is to be inside the sea, you will never have the feel. Okay? So that's the spirit, and with this spirit we shall start today's class where we had concluded yesterday. Okay? Alright. Now I see some of you have been asking questions to me from yesterday's class, and almost all that you've asked have already been answered by me in the thread that had started yesterday. So this is basically lack of effort making from your side, though I am absolutely committed from my side. I take my classes, I put a thread and I answer almost all the questions. Okay, I just reached home 30 minutes back. I just took a shower, got freshened up, had some fruits, and I'm here back with you. Okay, so let us start. So we had, what we had discussed yesterday was, we were discussing investigation of renal diseases, and we had discussed the routine urine examination in a lot of detail, where we had discussed the color, the specific gravity, the hematuria, the proteinuria, the types of proteinuria, detection of proteinuria, and quantification of proteinuria. And as far as I remember, we had halted at postural or orthostatic proteinuria. Am I right? Am I right? Very good, very good. Yes, Anudeep, cooker की सीटी बज रही है. I can also hear that, but I can't help that. My maid is probably making some dinner for me, so enjoy the background noise as you always do. Okay. Chalo. So we had completed proteinuria, and probably it was point number 5. So we shall now continue with point number 6. We shall now continue with point number 6, which will be pyuria. And pyuria is defined as more than equal to 5 WBCs per high power field in centrifuged urine. So 2 or 3 or 1 pus cell in a urine sample is absolutely normal. If you have more than equal to 5 pus cells or 5 WBCs in your urine sample per high power field, only then will you be considering it to be significant. Now, as soon as you get pus cells in a urine, your immediate instinct should be get a urine culture done. Why do I get a urine culture done? Because to confirm infection. Because the most common cause of pyuria is urinary tract infection. Because the most common cause of pyuria is urinary tract infection. Now, what if the urinary culture is positive for an organism, this is UTI. But what if the urinary culture is negative? If the urinary culture is negative on 2 occasions, so basically you will get a urinary culture. If it's negative, you will repeat the urinary culture. If it is still negative, then you can call it that pyuria which is not showing an organism, and when you do not have an organism, you call it sterile pyuria. You call it sterile pyuria. So the $1 million question is, does sterile pyuria mean that there is no infection or there was no infection in the urine? What I'm asking you is, does sterile pyuria mean that there is or was no infection in the urine? I will shortly answer your question. So if you get sterile pyuria, the causes of sterile pyuria can be infection related, and infection unrelated. So it could still be some infection related that has caused pyuria. So if it is an infection related, what do you mean by that? It could be partially treated UTI. You know, very recently, 3 days back, I got a call from a distant relative of mine saying that she's an auntie to me. She was like, "Beta, मुझे ना बुखार हो रहा है and I'm having some burning during micturition." So I was like, "Yes, auntie, you're probably having a UTI. So please get a urine RM and culture done." बेटा वो तो मैंने करा लिया. अच्छा auntie, please WhatsApp me the reports. Urine culture showed numerous pus cells. Urine culture was negative. So I was like, auntie, you please take down an antibiotic. I'm giving it to you. Your culture is negative, but probably the symptoms that you are telling me are suggestive of a UTI. So I prescribed her nitrofurantoin. She was like, beta, ये तो मैंने ले लिया. I was like, अच्छा ये भी आपने ले लिया? Then I was like, okay, auntie, let me do something. Let me redo a culture report. So just imagine the laymen have reached to such a level with the help of Dr. Google and Dr. Pharmacists that they themselves have diagnosed UTI based on clinical symptoms. They have even taken the first line antibiotic by themselves. And that is why the culture report was negative, because it's a partially treated UTI. And why was she still symptomatic? Because I just explained to her that, auntie, you will not get relief in just 2 days. It takes time for the antibiotics to work. So just continue the same antibiotics. So this is it. So it could be a partially treated UTI, or it could be tuberculosis, because tuberculous bacteria does not grow in normal bacterial medium. It could be fungal infection. In males, it could be prostatitis. Is it clear? Now, if it is infection unrelated, it means there is pus, but it is not related to an infection. Number 1, very common, patient has been recently catheterized. So, very commonly we see admitted patients having a Foley's catheter, urine sample being sent from the Euro bag, and you will say numerous pus. Junior will just say, sir, UTI है, sir, UTI है. अरे बेटा, आज तो पूछ तो लो सिस्टर ने कहां से सैंपल लिया है. सिस्टर ने पुराना यूरिन बैग से सैंपल ले लिया, which is having a lot of pus cells, does not matter at all. Next, having a recent urinary intervention. Like cystoscopy. So you basically have inserted a scope, just like you do an endoscopy from the mouth, a colonoscopy from the anus, cystoscopy from the urethra. So cystoscopy has been inserted into the bladder. So some instrumentation has been done. So that will create an inflammatory reaction. Inflammatory reaction means neutrophils. Neutrophil means denatured neutrophil means pus cells. Now what else? Very importantly for nephrologists, it could be interstitial nephritis. So basically it's an inflammation of the interstitium of the kidney, which is a non-infective inflammation, and it will give rise to pyuria. What else? A transplant patient has come to you, a patient who's had a recent renal transplant, and he comes to you, sir, I'm having a lot of groin pain, sir, and suddenly my creatinine has shot up from 1.5 to 3. I'm like, okay. I asked him, beta, did you miss your tablet that you take twice a day? I was basically hinting at tacrolimus. He was like, sir, yeah, I was a garib patient tha. He was like, yeah, sir, I could not take it for 3 to 4 days. So basically missed immunosuppressants, having a transplant, having an allograft, rejection, and when you have a rejection, there's an inflammatory reaction, and you will get pus cells in the urine. So there could be graft rejection also. So basically, today, if I ask you a true or false question, pyuria always means urinary infection, true or false? Sir, it can always be not due to infection also. And sir, आपने तो मुझे so many causes लिखवा दिए. There are other causes also, but these are the important ones. So pyuria necessarily does not mean infection, though the most common cause of pyuria is infection. The next point. Culture negative pyuria rules out infection. True or false? That is also not true, sir, because sterile pyuria can also be there in an infection like TB, fungal infection, or even a partially treated UTI. So we have cleared our concepts regarding pyuria today. Very good. Very good. Is it clear to all of you? Very good. So now, after having discussed pyuria, let us now enter into the next important domain of urinary examination, that is cast. That is cast. And I think this is point number 7. Now, many of you might be thinking, sir, from yesterday you are blabbering a word, cast, RBC cast and all that. What is cast, sir? Cast is nothing but accumulation of tam horsefall protein taking a cylindrical shape. So a guy from AIMS messaged me, sir, why cylinder, sir? Why not hexagon, sir? Because cylindrical shape, because it takes the cylindrical shape of tubule. So it is nothing but accumulation of tam horsefall protein taking the shape of the tubule. If tubule hexagonal hota, then cast also would have been hexagonal. Because the tubule is cylindrical, so it is the renal tubule, I mean, but it's taking a cylindrical shape. Clear? Now, many of you are still thinking, sir, you are blabbering this word tam horsefall protein from that point, sir. What is this damn tam horsefall protein? Sir, ये कौन सी खेत की मूली है, sir? Where has it come from? So basically, what is tam horsefall protein is? Tam horsefall protein, it is a protein. If this is the tubular cell and this is the tubular epithelium, so tam horsefall protein is secreted by tubular epithelium. If you remember, on the first day I have made a master diagram where I had showed from the aorta to the pelvis of the ureter and the urine outside. I showed you the renal tubule, the PCT, the loop of Henle, the DCT, the collecting duct, cortical and medullary. So I had showed you the tubular epithelium, the tubules in details. But which part, let me ask you a physiology question. Which part of the renal tubule secretes tubular epithelium? Is it PCT? Is it loop of Henle? Is it DCT, or is it the collecting duct? Some of you have correctly answered. It is secreted by the tubular epithelium of thick ascending loop of Henle and DCT. So yaad rakho, let me revise. I have told you 2 important MCQs about thick ascending loop of Henle. 3 important MCQs. If somebody can recall in his mind, kudos from my side. A high five from my side. Tam horsefall protein is the full form. It is secreted by thick ascending loop of Henle and DCT. So the 3 MCQs about TLH I have taught you till now are: number 1, it secretes tam horsefall protein. Number 2, it has a very important sensory organ known as macula densa. It has a very important sensory organ which has macula densa. Have I taught you anything else regarding thick ascending loop of Henle? Yes, sir. The thick ascending loop of Henle and S3 segment of PCT are vulnerable to ATN because they lie at the corticomedullary junction. कुछ याद आया? दिमाग की बत्ती जली? Please have a Mentos. Please have a Mentos. Okay? But don't consume it with a Coca-Cola or any soft drink, because you know all of you must have got that WhatsApp message that if you put a Mentos in a Coca-Cola bottle it bursts. Okay, so clear? ऐसा ग्रंथों में लिखा है, but I have read on WhatsApp. Hashtag Patal Lok. I saw it very recently though. Okay. So this is about TAM Horsfall protein. So if I have to make a schematic diagram, of TAM Horsfall protein, this is if my thick ascending loop of Henle और ये मेरा tubular epithelium है. So ये tubular epithelium will secrete a protein like this, which is the TAM Horsfall protein, और ये TAM Horsfall protein ultimately will condense like this and will accumulate. It will accumulate, okay, to form a cylindrical structure which is known as cast. So it is nothing but accumulation of TAM Horsfall protein. Now, a very important concept now. Let me give you a good concept. Very important concept. Some people have messaged that Tushar sir also cracked the same joke. Is it? Superb. Then I'll text to Tushar sir that हमारे विचार काफी मिलते जुलते हैं, because yeah, I do know that he's also fond of watching web series. So good. Now, yeah. So अगर ये ट्यूब्यूल है मान लो, and this is the PCT and the above part, and यहाँ से your urine was coming. Basically your water was coming from above and is now passing through a thick ascending loop of Henle, which is secreting the TAM Horsfall protein. So मान लो, to form cast, what is the prerequisite that you require? Sir, to form cast, I need two things, sir. I need one thing. I need this more. So I need excess of one and I need less of two. One is what? TAM Horsfall protein. Two is what? Water. Because sir, if excess water comes, it will bahar ke le jao the TAM Horsfall protein which is accumulated. So I want less of water ताकि TAM Horsfall protein gets the time to accumulate and form a cylindrical structure. Am I correct? Yes or no? So basically, if I want more cast, I want less water in my urine, and if I have more water in my urine, I will form less cast. I think this is absolutely clear to all of you. एकदम clear है. Clear? Now, okay. Some people are asking, sir, time कैसे मिलता है? I told you yesterday, time मिलता नहीं, निकालना पड़ता है. You never get time, you have to take out time. So, coming to cast. So this is the pathogenesis of cast formation. Okay? So I've given you the concept. Now, let us straight away jump into types of cast. Let us jump into types of cast. Okay? So, the types of cast are, number one, so we will make a table. This is the name of the cast. This is the composition. This is the composition. And this is the cause. Okay, so let's discuss hyaline cast. So hyaline cast is made up of TAM Horsfall protein. So basically I told you, if you have less of water and more of TAM Horsfall protein, you will form a cast, and that cast is known as hyaline cast. So if you drink less of water, that is known as dehydration. That is known as dehydration, or it could be found in normal urine also. It could be found in normal urine also. Is it clear? Now hyaline caste is found in normal urine also. So that which is found in normal urine also has to be the most common caste. And because it is the most common caste, of course, it is not that dangerous. So it is also known as benign caste. Benign matlab not dangerous. And because of its refractive index, it is also known as transparent caste. So hyaline caste or benign caste or transparent caste is formed of TAM horsal protein and is found in dehydration or in normal urine. I hope I am absolutely clear to all of you. Clear? Now, next. Okay? Guys, I request you all to please stop your side talks in your chat box, because you know, more than distracting me, you are distracting yourself. Please listen to me. I told you listening is the best quality. Okay? Though I am not a very big learned person, but you know, I always, you know, tell my friends, my students to read one book, and I do not promote that book as a religious book. You might belong to any religion. But I think there is one book, and I read as a motivational book, and that book is known as Bhagavad Gita. It has numerous, you know, chapters, but it has so much of motivation, and I feel every motivational seminar has been ultimately etched out from that book only. And you know, that book is basically where, you know, when the Pandavas were fighting the Kauravas, in the middle of the Yudh, Arjun gave up on his armaments. He said, I cannot fight. And that time, Lord Krishna, he answered all the doubts that you and me we could have in any part of our life in Bhagavad Gita. And you know, the best part is, in the first 2 chapters, Krishna has not spoken in Bhagavad Gita. The first 2 chapters, though Bhagavad Gita is all about Krishna, but in the first 2 chapters only Arjuna speaks his heart out. So what do you learn from that thing? You learn that why did Lord Krishna not intervene in the middle of Arjuna speaking? Because he was a very good listener. He knew that if I listen properly, 90% of the things are clarified then and there only. So please be a good listener. If you stop me in between, if you keep on asking such things, or if you keep on continuing such things, you are basically losing out yourself. Okay? Okay? So, I was talking about hyaline caste. After hyaline caste, let us discuss about the next caste, and I shall go it the other way now. There is a disease in nephrology which is known as acute tubular necrosis, which is abbreviated as ATN. I have written it 100 times. And what is ATN? ATN is basically, if this is the tubule and if this is the tubular epithelium and this was the TAM horsewall protein, right? And I know Shakespeare had said what's there in the name. Shakespeare had said what there in the name, though उसके नीचे उन्होंने खुद ने अपना नाम लिख दिया था. But you know, I totally disagree with this. I believe everything is there in the name. ऐसे मेरा नाम विवेक थोड़ी ना है. Here, so basically, what I mean is, if you can decode the name of a disease or an entity more than half the number of times, you can ultimately understand what it is. So the disease का नाम है acute tubular necrosis. Acute meaning which is happening suddenly. Necrosis का simple word है death, and tubular means renal tubule. So an acute process where there is a death of the tubule, and you know that Prakriti का नियम है, anything that dies is shed off. Anything that for humans also. So when the tubule will die, it will be shed off here, and this will be shed off here. The necrotic debris. So this TAM horsewall protein pe the necrotic debris will accumulate. Am I clear? Yes or no? So this will ultimately have TAM horsewall protein plus necrotic debris. Yes or no? Yes or no? So this TAM horsepower protein plus necrotic debris in acute tubular necrosis, and anything that has necrotic dead material, is it looking dirty or is it looking very, very clear? Is it gandagi hai na? So it is looking dirty, and that which is dirty, of course, is signifies muddy brown cast or granular cast. So this is known as granular cast. So muddy brown cast or granular cast is seen in acute tubular necrosis, is composed of TAM horsepower protein and necrotic debris. I hope I'm absolutely clear. Moving on. Moving on. Moving on. Say there is a disease known as chronic kidney disease. Now, there was a tubule which was secreting a cast, which was secreting TAM horsepower protein, and it was forming a cast like this. You know that the hallmark of chronicity is, the pathologic hallmark of chronicity is what? It is fibrosis. And when there is fibrosis, there is pulling. Pulling, yes or no? Not strilling, pulling wala pulling. Pulling, P-U-L-L. So, this tubule will be pulled from year to year. Yes or no? And because tubule will be pulled from year to year, the cast will also be pulled from year to year. Because I told you, cast is nothing but takes the shape of the vessel. So, if tubule chauda hoga, to cast will also be chauda. And this cast now, is it narrow to look at or is it broad to look at? Is it narrow or is it broad? It is broad. Yes, you are correct. So because it is broad to look at, this is known as broadcast. It is known as broadcast. Is it clear? So broadcast is found in chronic kidney disease. See how you can derive the disease and the name of the cast if you have the concept. Am I clear to you? Am I clear to you? Very good. Very good. Next. Now broadcast is also known as waxy cast. Broadcast is also known as waxy cast, and of course if a patient has broadcast or waxy cast in his urine, उसे ये तो नहीं बोलोगे कि बेटा good news, you have a great news. Of course not. उसे dull voice में, dim voice में, कंधे पे हाथ रखकर consolation के साथ you will say that the kidneys are not in a good shape. Okay? Okay? So it has a bad prognosis. It has a bad prognosis. Is it clear? Pulled because of fibrosis, beta, fibrosis. Clear? Is it clear? Due to fibrosis. Now after broadcast, let us quickly do the rest of the cast. Let us now take RBC cast. RBC cast is formed of RBC, and the causes are: number 1, glomerulonephritis, number 2, vasculitis, which you have studied very nicely, I know, in Sinath sir's class. Number C, thrombotic microangiopathy, and number D, malignant hypertension. Can you give me an example of thrombotic microangiopathy? Any one of you? Yes, you have studied the names at least once for sure in your microbiology class. They are hemolytic uremic syndrome and thrombotic thrombocytopenic purpura. Just to give you a perspective, though this will be taught to you in your pathology and hematology class, and just giving you a perspective. Clear? Clear? Beta, composition of broadcast is nothing but TAM hot cell protein. Broadcast is also formed of TAM hot cell protein only. Clear? TTP is thrombotic, thrombocytopenic purpura. This is a very important PGI Chandigarh question. RBC caste, ये तो सबको पता होता है, ये भी सबको पता होता है. But these is where the people get stuck. And those who want to crack PGI Chandigarh and AIMS also, because in AIMS also now you have multiple correct answer, you must know everything. Clear? Clear? Good. I will just change the page because now we have done RBC caste. Now come to WBC caste. Somebody is asking me which vasculitis. Now tell me, you've already been taught rheumatology, which type of vasculitis causes glomerulonephritis? Obviously glomerulus is a bunch of capillaries, and capillaries is a small vessel, medium vessel or large vessel. Quick. Obviously small vessel. So from your common sense, small vessel vasculitis will cause glomerulonephritis, and small vessel vasculitis will have RBC caste. So see, everything can be derived from the name only. WBC caste formed of WBC. It is found in number 1. I know every one of you know it is found in pyelonephritis. And trust me, इसमें कोई credit नहीं है. It is also found in interstitial nephritis. I will also not be that glad if you answer this to me, because I know you all are brilliant students, you will answer this. But because you are Dr. Vivek's sir student, you must know the third answer also, which will be the defining or that watershed region between good students and very good students, that is graft rejection. I told you graft rejection causes pyuria, and because that pus cell come from inside the glomerulus, that will form a WBC caste also. So this is very, very important. This is very, very important. Clear? Am I clear? देखो, many of you are asking me कि whether TAM hot cell protein is present in all the caste. That is basically the inside part, the nucleus of any caste. उसके ऊपर whatever settles. If RBC settles, it becomes an RBC caste. WBC settles, WBC caste. Necrotic debris settles, granular caste. Am I clear? TAM hot cell protein is present in everything. Clear? Now, after WBC caste, next take eosinophil caste. It is formed of eosinophil plus TAM hot cell protein. And eosinophil caste is found in acute interstitial nephritis. Acute interstitial nephritis. Clear? Clear? Thank you, Abhida Tanveer AM, for prescribing me such a great drug. Thank you so much. Okay, eosinophil caste. Don't worry, I don't have COVID. I just got it tested the day before. I got to COVID tested. Okay, because I have had so much of exposure. In fact, I've already had 4 tests in the last 1 month. Okay. Some people in my department were even calling me a COVID broadcaster, because any patient I used to see unarmed, that patient turned out COVID positive. But thankfully, by God's grace, I am here in front of you. Chalo. So after eosinophil caste, what else? You can have a lipid caste. And a lipid caste is formed of cholesterol. It is formed of cholesterol, and it is found in, absolutely correct, it is found in nephrotic syndrome, which I will be teaching you today. This is very, very common. Clear? Yes, beta, allergic and acute is same. Initially it was known as allergic, now it has been termed as acute. Allergic interstitial nephritis and acute interstitial nephritis is the same thing. Is it clear? Clear? For practical purposes. Actually, it is better to say allergic interstitial nephritis is a type of acute interstitial nephritis. But it is same thing only. That's the thing, Amrut SK. Positivity, positivity. And I, always say that I'm not a COVID broadcaster. I'm a smile broadcaster, and I want to be a smile broadcaster. But sometimes it has become so problematic that at times you have to be very consoling and you have to show a bit of grief. And I have a tendency to show my 32 teeth. So, I have a tendency to smile. When I walk by. It's a reflex action for me. So, whenever, I have to disburse some bad news or not so good news, then, I consciously try to regain myself, and I'm like, yeah, okay. So, now I have to be a bit more serious and like that. Otherwise, I'm always like this all the time. So, that's become a very, very inherent part of me. And I would always request all of you to be always, broadcast smiles, because it doesn't take a penny, but it spreads positivity. Okay? So you should be such, if you should enter a room by, which can have 100 people inside the room, but when you enter, there must be a wave of positivity inside the room. You must be able to make a difference. If that you can do, trust me, you are going to go far. Okay? And after lipid caste, let me give you an edge. Let me give you the last caste of the day, which is not mentioned in your Granth also, in your Guru Granth Sahib or Bhagavad Gita, that is Harrison also, that is decoy cell caste. And my prediction is this is going to be asked very, very soon in one of the exams. It is very, very important. Decoy cell caste, and I always, whenever I teach, I put it as a silk Cadbury question. And in any class I teach, I usually say that if anybody answers where is it found, I will give him a Dairy Milk silk, so that stakes are high, people are motivated. Until now, last year 3 people, one from KMC Manipal, one from Lady Hardin Medical College, and another guy from probably one of the cities of Madhya Pradesh, Indore or Bhopal, they managed to get this from me. And I can already see Pramod Bhatt and Abhilash Patwari correctly answering it. Superb. Very good. So, decoy cell caste is basically, it is formed of cell with nuclear changes, and it is found in BK virus, which is a type of polyoma virus nephropathy, and BK virus nephropathy does not infect you and me. It infects transplant patients, transplant recipients. So BK virus nephropathy patient will have a decoy cell caste in your urine. So we have done all the 8 types of caste in details. Please understand this. I could have easily given you one word answer. RBC caste this, WBC caste this, granular caste ATN. But no, I want you to understand so that in the exam you don't have to memorize. So आप कैसे याद करोगे? Acute tubular necrosis. Necrosis means death. Death means sloughing. Sloughing means necrotic debris. Necrotic debris means dirty. Dirty means muddy brown caste. CKD means fibrosis. Fibrosis means pulling. Pulling means broadness. Broadness means broad caste. So you can derive all the caste. You don't have to mug it up. Am I clear? If this way you go, nobody can stop you. I hope I'm absolutely clear. So after caste, let us now enter into the next topic, the last portion of urine examination. Transplant recipients, beta, transplant recipients. The last portion of urine examination, that is crystals. That is crystals. Clear? Are we good to go? And we shall not only write down the name and the shape of crystal, but you also have to know the photographs. So let me show you photographs also. So this I told you, monomorphic versus dysmorphic RBC. This is present in non-glomerular hematuria. This is present in glomerular hematuria. I hope all of you remember it very, very clearly. This is the RBC caste. This is the RBC caste. Please have a look. This is the hyaline caste, which is also known as transparent caste, which is the most common caste. I hope you remember everything. This is the WBC caste. You will not be asked to identify the caste. Don't worry, okay? Don't worry at all. This is the granular caste. Granular means muddy brown, found in acute tubular necrosis, asked n number of times in the MCQ exam, n number of times. This is the waxy caste or the broad caste, found in chronic kidney disease. I will share the photographs, don't worry beta. Now, the topic at hand, coming to crystals. What will you write in your notebook? You will write calcium phosphate crystal hyphen star like brushite. So you can be asked this topic in three ways. MCQ can ask you calcium phosphate crystal is dash shaped. Answer star like brushite. They can ask you star like brushite crystal is which crystal? Answer is calcium phosphate. Or they can give you the photograph and ask you to recognize the type of crystal. Am I clear? So you will write down calcium phosphate hyphen star like brushite. Am I clear? Next, write down struvite crystal bracket में triple phosphate is coffin lid crystal. You know, when I first read this, I thought that pakka ye pathologist must be attending a funeral and coming to his work. तभी इसे microscope के नीचे भी coffin का lid दिख गया. Such imagination, you know. And you know, pathologists have great imagination. Somewhere they can see a starry sky, and somewhere, you know, onion ka प्याज का छिलका तो they have seen at least n number of places. One in neurology, one in EA, one in CIDP, and whatnot. I forgot everything. Don't ask me to answer those things. But you know, when I saw this figure, it is really looking like a coffin lid, yaar. So kudos to pathologists. They do wonderful work. How they create analogy, superb. So this has been asked very many number of times. Very important. So coffin lid crystal or coffin lid shape is struvite crystal or triple phosphate crystal. So you have to know all the three things: name, shape, and the photograph. Next, amoxicillin crystal or branch of a broomstick. So amoxicillin causes branch of a broom. So is there anyone who has not consumed an amoxicillin tablet anywhere? Anyone who has not consumed an amoxicillin tablet in his life? Probably no one. I have consumed it many number of times. So next time when you take this tablet for NRTI or URTI, please try to find a jhadu in your urine. And whenever you see a jhadu or a broom in your room or your mess or your hostel, please be reminded of amoxicillin. So amoxicillin, jhadu, amoxicillin. If you do this way, you will never forget medicine. This is the charm to learn medicine. Is it clear? Yes, लिखना है साथ साथ में. Please write down amoxicillin, branch of a broom. Nothing so big rocket science. Next, ciprofloxacin, star-shaped. Now you know if I was the pathologist here, probably I would have named it Diwali cracker crystal because it is looking more like a Diwali cracker to me. But thankfully I am not, and I am better off seeing whatever doing whatever I do. So ciprofloxacin causes star-shaped crystals. Now please remember there are two stars here. One is ciprofloxacin versus calcium phosphate. दोनों को एक साथ देखो, then you will remember. This you see, this is star or Diwali cracker ciprofloxacin, and this is star-like brucite, which is calcium phosphate. Now you know how did I remember all these when I was in your standard? I was never as intelligent as you all are, and you know I had this habit of integrating medicine with lame things. So मैं चीजों का नाम याद रखता था with cricketers name, with movies, with whatever I loved. So how did I remember? So I remembered calcium phosphate. Phosphate means 5. 5 means 5 star. Star means star. I was very fond of 5 star. So I never forgot. So calcium phosphate. Phosphate say 5. 5 say 5 star. Star say star. So lame na? You might not follow it. You all are very intelligent. But you know I was like this only. Clear? So, and this directly taken from Jipmer 2018, asked in Jipmer 2018 exam, envelope shaped crystals are calcium oxalate. See, beautiful. It is a beautiful envelope. Absolutely an envelope shaped. This is an envelope shaped crystal. This is an envelope shaped crystal. You know, whenever I teach this, I am my ears reverberate. You know, I was hosting a ceremony in my school in class 10, and you know, from the podium I was reading something and I read envelope. I said envelope, and from there my English teachers, you know, shouted from the back of the auditorium, Vivek, it's not envelope, it's envelope. So, you know, whenever I say this word, it's so much built in my subconscious that, you know, when I was going to read it, I was telling to myself, it is not envelope, it is envelope. This is how you pronounce it. So, here, that's a separate story. This is how, you know, life reminds you of certain things. These small incidents, but they have a big impact on you. And last but not the least, uric acid crystals, which will be diamond shaped. So this is a diamond shaped crystals which are formed by uric acid. Now very recently, just before my nephrology class, you have studied in rheumatology that uric acid crystals are found in one more place. Do you remember that? Some people are like, sir, nephrology पढ़ा रहे हो, nephrology में रहो, why are you deviating to other subjects? But beta, probably I also passed MD medicine na. So when I studied MD medicine, I probably studied all the parts of medicine. So I know a bit of all. Not very much, but I do know a bit. So uric acid crystals can be found in the urine or can be found in the joint. And when it is found in the joint, that condition is known as gout. Absolutely clear? Or MSUD. I hope you know the full form of MSUD. Very good, crystal arthropathy. So, when it is found in the joint or gout, it is needle shaped. But when it is found in the urine, it is diamond shaped. How to remember this, sir? Sir, is ever a diamond pain? दोनों में से painful क्या है? Needle या diamond? Sir, of course, sir. Who girls are saying, sir, how can a diamond be painful, sir? Diamond, sir, give us a diamond and win our heart, sir. No, I'm just kidding. I know it is much more difficult to win a heart of a woman, you know. So a needle will not be. A diamond won't be sufficient. So of course, a needle is very painful. And what is more painful than a gout? A gouty joint is the epitome of a painful joint. It is such a painful joint. I have seen a 45-year-old male, even my own uncle had gout, and he was crying in pain. And it's not a good sight to see a middle-aged, grown-up, healthy man to cry in pain. Gout is so painful. So a painful joint obviously will be having a needle. And so diamond is of course not at all painful. So it will be found in the urine. So now you've understood that needle, pain, joint, diamond, urine. So you have understood uric acid crystals have a different shape both in the urine and in the joint. Clear? Absolutely clear? Very good. Very good. I am very, very happy with you all. So with this we have completed the the urine examination. And let us do this question for me. And first you answer this question, then I will tell you where did this question come. And then you can give a pat on your back to all of you from my side. This question is, decoy cells in the urine is associated with TB of the urinary tract, cellular rejection, bladder carcinoma, or BK virus infection in transplant patients. Can you tell me what is the correct answer? What is the correct answer? You are absolutely correct. Correct answer is BK virus infection. And you will be very, very happy and surprised. This was asked in all India DM nephrology entrance exam. This was asked in all India DM nephrology entrance exam. Some people are like, sir, ये किस खेत की मूली है? बेटा समझो, क्लास 10 के बाद क्लास 12. क्लास 12 के बाद you have the NEET entrance to which you get MBBS entrance. MBBS entrance के बाद where you are standing right now, MD entrance. And you are thinking that once I get MD, clinic के बाहर तो लाइन लगा दूं, Gynecologists are thinking, sir रोज 2-3 LSCS, 1-2 vaginal hysterectomy, sir 1-2 ये. Orthopedicians are thinking, sir दिन में 2-3 TKR, 2-3 hip replacement and what not. Physicians are thinking, sir patient तो देखूंगा ही नहीं sir मैं ज़्यादा. I will reject all the patients, sir. But trust me, life is not as easy and hopeful as it seems. The moment you will complete your post-graduation, then you will come to know that some another tunnel is waiting for you at the end of the road, and that is your super specialty entrance. So people who are very smart and not foolish like me will probably choose end subjects like radiology and orthopedics and whatnot. Okay, that's a separate story. So you are even cracked DM nephrology entrance exam questions. So kudos to you and pat on your back. All right. With this, we complete the investigation of nephrological disease, and we now begin the next chapter. Yes, Manmohan Singh, you can take admission in DAMS because DAMS is the only institute in the country that provides coaching for DM nephrology entrance also. In fact, that course also has been made by me. Okay. So now let us enter into a very interesting chapter that is glomerular diseases. And I know that you have already had your systemic pathology class and you have been taught glomerular diseases in a lot of details by a pathology teacher. Clear? I know that very well. Ciprofloxacin beta star shaped crystal. वो दिवाली cracker crystal था ना? Diwali cracker crystal, it is that. Clear? So now let's enter into glomerular diseases. And we shall now begin with the very basic. I will just revise anatomy of the glomerular filtration barrier, though I know you all of you are champions in it. So let us revise the anatomy. I will just tilt the screen now so that I can draw the anatomy of filtration barrier. Now, The filtration barrier is a 3-layered barrier. It is a 3-layered barrier which is composed of, first layer is the endothelium, then you have the glomerular basement membrane, and then you have the foot process of the podocytes. So this is the first layer, which is the endothelium. This is the second layer, which is the glomerular basement membrane, and which is the third layer. This is the foot process of the podocyte. So this is the fenestrated endothelium, and you know fenestra means holes. This is the second layer, which means glomerular basement membrane. This is the glomerular basement membrane, and last but not the least is the foot process of podocytes. Am I clear? You can very well see that there are fenestra between the endothelium. There are fenestra between the endothelium. I hope I'm absolutely clear. So there is a fenestrated endothelium, then there is a glomerular basement membrane and foot process of podocytes. Now let us discuss something about each, and let me tell you some MCQs about each, which can be asked in your anatomy, physiology, medicine, or whichever subject you can call it. Number 1, about fenestrated endothelium, they have fenestra which are 50 to 100 nanometer in diameter. This is an MCQ. And endothelium is negatively charged. Endothelium is negatively charged. Please remember this. Next, coming to GBM. Glomerular basement membrane is a trilaminar basement membrane which is composed of, number 1, collagen 4, number 2, laminin 11, and number 3, heparin sulfate proteoglycan. Might be in your physiology you have been taught 70 to 100 nanometer, but in my nephrology books it is written 50 to 100 nanometer. Reference is Fiali's textbook of nephrology, which is the Bhagavad Gita or the Bible or the Quran of nephrology. So I do have a reference. Some values still differ, so you might choose according to the options whatever is available. Okay? So this is the composition of GBM. Now, what are the chains of collagen 4 that form the GBM? It is the alpha 3, alpha 4 and alpha 5 chains of collagen 4. Basement membrane is also negatively charged, which is imparted by the heparin sulfate proteoglycan, which itself is an MCQ. Am I clear? It is laminin 11. So endothelium is negatively charged. GBM is also negatively charged, which is due to heparin sulfate proteoglycan. Next, coming to the last layer, which is the foot process of podocytes, which is basically something like this. Acha, what are podocytes? I told you about podocytes, but I didn't say what is podocytes. I hope you should be knowing this. Podocyte is nothing but the visceral epithelium of Bowman's capsule. So the visceral epithelium surrounding or covering the Bowman's capsule of the nephron is known as podocytes, and that podocyte has lot of finger-like projection or interdigitations, and those are known as foot process. So these are the foot process of podocytes, and as you can clearly see that there are slits between there is a slit between the foot process of podocyte, and that is known as filtration slits. That is known as filtration slits. Is it clear? So these are holes, filtration slits that have a width of 30 to 40 nanometer. But are these slits naked? Are they open? No sir. They are covered by a proteinaceous porous membrane. Proteinaceous membrane which is known as slit diaphragm. So this is a membrane which covers the gap, and that is known as slit diaphragm. But do remember one more MCQ, slit diaphragm allows only 4 nanometer substance to pass through it. Am I clear? So basically the filtration slits was 40 nanometer. उसके ऊपर एक membrane came which was a selectively permeable membrane, so that was only allowing substances of 40 nanometer to pass through it. So you have learned two numericals here. Ki first it was 30 to 40, but it was allowing only 4. And so you have understood that 4 nanometer substance can pass through it. Very good. Very good. Am I clear? And very, very important, the slit diaphragm is also negatively charged. So you have understood very clearly that my entire filtration barrier is negatively charged. My entire filtration barrier, all the 3 layers are negatively charged, and thankfully so, because you know that the size of albumin is 3.6 nanometer. Is 3.6 less than 4? Is 3.6 less than 4? मैंने जब last maths पढ़ा था 3.6 was less than 4. So if 3.6 is less than 4, then all of us should be losing all the albumin in the urine, and all of us must be having nephrotic syndrome. All of us must be having nephrotic syndrome, yes or no? If it is so, why are we not having it? We are not having it, thankfully, because of 2 properties of a filtration barrier. Number 1, the properties are, number 1, size selectivity, and number 2, charge selectivity. So at least we have both the things, and had we not have charge selectivity, we would have lost albumin in the urine, because albumin is negatively charged. Albumin is negatively charged, so the filtration barrier repels albumin. Is it clear? That is why they repel. Had they not repelled each other, we would have been losing albumin like hell, and all of us would have been having anasarca with our eyes swollen, our body swollen and difficult to walk, and daily our slipper size would have been different. Clear? Absolutely clear? Very good. Very good. So we have understood the physiology of the filtration barrier, and now we can see, don't be stuck in a small value change here and there. Different books have different references. Try to understand the concept. Is it clear? Okay. Now we shall enter into the glomerular disease proper, and before we enter, let us understand the ultrastructure. So you must have seen your pathology books, that is Harsh, Mohan, Robin, whichever book you study, having a lot of pink figures in your glomerular disease chapter. And trust me, let me confess, when I was in second prof, I did not understand that very well. Still I'm very poor with slides. I absolutely become, dyslexic when I see a microscope. Clear? So let me easy things for you, and let me give you a schematic diagram of how things look under a microscope. And why? Because you have been studying so many number of times कि this deposit, subendothelial, ये deposit, वो deposit, and you miss and you muggle up everything in the end because I told you, your mind thinks in figures, and if you cannot visualize something, you cannot memorize that thing. I told you, apple, not APPLE, but a round color fruit. But Wegener's, WEGENER, because you have never seen a patient of Wegener's granulomatosis. So this is the difference. So today I will teach you how to visualize things. So मान लो, this is your endothelium, this is your GBM, and this is your foot process of podocytes. Now please understand, this is a schematic diagram, okay? Neither am I a pathology expert, nor am I saying you exactly it will look like this, but schematic diagram to samajhte ho? Very good. So this is your layer number 1, which is endothelium. This is your layer number 2, which is GBM, and these are your interdigitations or foot process of podocytes. So if I have a deposit over here, I know this is nothing but, you have been hearing the term since time immemorial, subendothelial deposit. If this deposit is here beneath the epithelium, this is known as subepithelial deposit. And here you have some supporting cells which are known as mesangial cells. These are mesangial cells. And if you have any deposits here, you know that these deposits are known as mesangial deposits. Some people are saying, sir, आप क्यों इतनी पैथोफिजियो मेडिसिन पढ़ा रहे हो? I don't know everything. There is a problem with me. I know there's a problem. The problem is I just cannot straight away jump to post-streptococcal glomerulonephritis or subendothelial deposits, because I clearly relate to those students who may probably had read these things in the basic classes but have forgotten now, and I am actually catering to every one of you. I want to cater to all of you. So I want to bring everything together, and this is the way medicine has to be learned. You have to know everything. You have to know the renal physiology, pharmacology, pathology, medicine, everything. If you know everything in your grip, तब तो learning is fun. You will want to learn. आपके मन में चाह आएगी. But otherwise, if I teach you today PSGN like this, tomorrow if I teach you MPGN, you will not be interested only because you will think, sir, again will utter something which is Greek. Clear? So you have understood that there are subendothelial deposits, subepithelial deposit, mesangial deposit. Can you tell me an example of subendothelial deposit very quickly? Can you tell me an example of a disease where there is subendothelial deposit? Yes, post-streptococcal glomerulonephritis. Post-streptococcal glomerulonephritis. Can you tell me one disease where there is subepithelial deposit? बहुत सारे हैं. मैं आपको एक example, that is membranous glomerulonephritis. Membranous glomerulonephritis. Example. Can you tell me a disease where there are mesangial deposits? Yes, I know, sir. IgA nephropathy. IgA nephropathy. IgA nephropathy. बहुत ही बढ़िया. Superb answering all of you. Kudos. चलो बहुत बढ़िया. Clap from my side. So now we have understood the filtration barrier का anatomy, physiology, and we've understood pathology में कैसा लगता है. Now medicine is fingertips, and you know what we shall do? By the end of this class, we shall make this figure so many number of times. मैं आपको ये इतनी बार बनवाऊंगा, इतना इसके बारे में नॉलेज दूंगा कि आप ये भूल जाओगे कि इस नॉलेज को रखे कहां. I tried to create an analogy with a dialogue, but probably the impact did not come. Here, forget that. So now, let us quickly jump. All of you who are now excited to learn the next topic. I know that. So now, let us quickly jump into the next topic. I mean, the proper disease, that is nephrotic syndrome. And you know, nephrotic syndrome is characterized by, number 1, proteinuria. Nephrotic syndrome is characterized by proteinuria, but कितना proteinuria sir? Sir, adults में कितना और pediatric में कितना? So you must know both the criteria, because you know examiners are really bluffing you nowadays. They ask you both. So you must have more than equal to 3,500 milligram of protein per day, or urinary PC ratio more than equal to 3,000 milligram per gram of creatinine. So proteinuria more than 3,500 milligram per day, or PC ratio more than 3000 mg per gram of creatinine in adults, and more than equal to 2000 mg per gram of creatinine in pediatric population, or more than equal to 40 milligram per hour per meter square body surface area. Let me tell you, all the 4 figures are important MCQs. All the 4 figures are important MCQs. So what is the criteria of nephrotic proteinuria in adults? It is more than 3,500 milligrams per day, or PC ratio more than 3,000 in adults, more than 2,000 in children, and more than 40 mg per hour per meter square body surface area. So this is the first feature of nephrotic syndrome, that is proteinuria. Next, after proteinuria, the next important thing is hypoalbuminemia. There is hypoalbuminemia. Sir, kitna hypoalbuminemia? How much will the albumin be? Sir, it will be less than 2.5 grams per dl. Hypoalbuminemia will be less than 2.5 grams per dl. And if I ask you a very basic question, why is there hypoalbuminemia? Come on, tell me. So I know most of you will tell me the correct answer, that is due to proteinuria. So if you are answering, or if you are appearing for all India postgraduate entrance exam, that is next or NEET or whatever, your answer is correct. But if you are trying to appear, if you are going to appear for AIMS or PGI Chandigarh, this is not enough. Hypoalbuminemia is number 1 due to urinary loss of protein. Number 2, due to increased catabolism. Number 3, decreased synthesis. So it is not merely the loss in the urine that is contributing to less of protein in the body. It is loss also, catabolism also, and less factory making also. All the 3, and this is an ex-PGI Chandigarh question. Clear? You know, a girl messaged me yesterday, sir, why do you keep telling, sir, ye PGI, ye Ejekmar, ye. Now let me tell you what I have done is, I have incorporated the 5 years questions of All India, AIMS, JIPMER, PGI, everything in my notes. So basically, if you are studying with me, if you are making notes with me, you are solving those 5 years questions also. You need not solve them separately. Everything is there in my notes. So okay, so do not worry at all. Protein creatinine ratio, beta, protein creatinine ratio. Clear? Number 3. Next, after proteinuria and hypoalbuminemia, what else can you have? You can have, or you will have, anasarca. And most of you already know that anasarca means generalized edema. And if I ask you, sir, what is the cause of anasarca? Anasarca का cause क्या है? I know most of you will answer hypoalbuminemia. The most common cause of anasarca is hypoalbuminemia. Catabolism increase because it's an inflammatory condition. Nephrotic syndrome is an inflammatory condition. Clear? The cause of anasarca is hypoalbuminemia, which is the most commonly given wrong answer. Because the most common cause of hypoalbuminemia is sodium and water retention. It is sodium and water retention. Clear? This is also an MCQ. Next, after anasarca, what else will you have? You will have hypercholesterolemia. Why will you have hypercholesterolemia? You will have hypercholesterolemia because you know you are losing proteins, so your body will try to compensate for it, and there is increased compensatory synthesis of lipoproteins. So hypercholesterolemia causes increased synthesis, compensatory synthesis of lipoproteins. So there was a question that the increase in cholesterol in nephrotic syndrome is not associated with atherogenicity. Atherosclerosis is not at all increased by nephrotic syndrome. True or false? Absolutely false, because the hypercholesterolemia leads to increased atherogenesis. There is an increased atherogenesis. Atherosclerosis ka rate or the tendency for atherosclerosis increases due to hypercholesterolemia in nephrotic syndrome. Last but not the least, the last feature of nephrotic syndrome is lipiduria. So you will get fat droplets in urine. You will get fat droplets in urine, and these flat droplets, when viewed under polarized microscope, will give you an MCQ. They will give you an MCQ that is Maltese cross appearance. So basically, lipiduria will cause which type of cast? They will cause lipid cast. And these lipid droplets, when viewed under a polarized microscope, they will have Maltese cross appearance. I hope it is crystal clear. So just revise with me. Nephrotic syndrome is characterized by proteinuria, hypoalbuminemia, anasarca, hypercholesterolemia and lipiduria. I hope I'm absolutely clear. All the five. Superb. Superb. Okay? Very good. Very good. Now, what are the complications of nephrotic syndrome? What are the complications of nephrotic syndrome? The complications of nephrotic syndrome. The complications of nephrotic syndrome are number 1. देखो यूरिन में प्रोटीन तो लॉस हो गई. Along with protein, there will be loss of immunoglobulin. There will be loss of vitamin D binding protein. There will be loss of thyroxine binding globulin. There will be loss of transferrin. And there will be a hypercoagulable state. So these are the primary 5 complications of nephrotic syndrome. So if you have loss of immunoglobulin in the urine, there will be an increased risk of infection. If you lose vitamin D binding protein in the urine, you will have hypovitaminosis D. You will have hypovitaminosis D. If you lose transferrin in the urine, you will have iron deficiency anemia. You will have iron deficiency anemia. And if you lose thyroxine binding globulin in the urine, आप अगर thyroid profile कराओगे, so you will get low T3, low T4, but as soon as you will get low T3, low T4, you will think, oh my god, my patient is having hypothyroidism. So then you will get a free T4 done, which is normal, and a thyroxine stimulating hormone done, which is normal. So actually, it's a euthyroid state, but the total hormones will decrease. So इसे देखकर ऐसा लगेगा कि दूर से देखा तो हाइपोथायरॉयडिज्म लग रहा था, पास जाकर देखा तो यूथायरॉयड निकला. Is it clear to you? So actually, that is why it is said, never, when you ask for a thyroid profile, never order T3, T4, TSH. Always order FT4 or free T4 and TSH. But you will still see old doctors 60, 70, in their pen they still have a reflex writing T3, T4, TSH. Because T3, T4 is the total hormone and they can be varied or altered if the protein content in the body is altered. So in conditions wherever there is a protein change, you can have difference. Is it clear? Last but not the least, a hypercoagulable state. Somebody said joke in English, sir. So when you saw from a distance, it was appearing hypothyroid. When you went near it, it was euthyroid. Is it clear? Clear? Thank you. So hypercoagulable state is a very, very important because there is loss of something and there is increased synthesis of something. There is loss of antithrombin 3, which is an anticoagulant. When you lose anticoagulant, when you use anticoagulant, you basically have a procoagulant state, and there is synthesis of factor 5, von Willebrand factor, and fibrinogen. So this is the cause of hypercoagulable state, and this has been asked in numerous MCQ exams. Antithrombin 3. This I am giving you extra. I am giving you extra for your Central Institute exams. Clear? Clear? So these are the complications of nephrotic syndrome. So now, without any much delay, we shall start with the disease proper. Clear? So let me post 3 MCQs in front of you. Most common cause of nephrotic syndrome in children, in adults, which is a primary cause, secondary cause, or overall. So I have given you 4 MCQs. Let me see who answers them fast. Who answers them fast? So in children, the most common cause of nephrotic syndrome is minimal change disease, is MCD or minimal change disease. The most common cause of nephrotic syndrome in adults, which is the primary cause of nephrotic syndrome, is focal segmental glomerulosclerosis, FSGS. The most common cause, which is a secondary cause of nephrotic syndrome in adults, is obviously my Pujaniya, your Pujaniya, the capital of the country, the non-infectious capital, disease capital of the country, that is diabetes, Sir Diabetes mellitus. Sir Diabetes mellitus. And last but not the least, overall, suppose nothing is mentioned, primary, secondary mentioned ही नहीं है. So what do you think is more common, FSGS or diabetes? Has anyone seen FSGS among you all? I don't think anyone has seen, or if anybody has seen, there will be 1 or 2. Has anyone seen a diabetic patient? Beta, you go out and you will, बाहर चलोगे 10 से टकरा जाओगे. The moment you start walking, you will strike against 10. So of course there is no question which is common between the two. Diabetes is 10 to the power n times more common than FSGS. Of course it is Sir Diabetes mellitus. No question. And it is obviously a MCQ. Is it clear? Absolutely clear, I hope all of you. Good. So now let us enter into the types, the nephrotic syndromes. So if you have, so we have 3. So let me classify it for you. If you have to classify nephrotic syndrome, they can be primary, they can be secondary, or they can be congenital. Yes, they can be congenital. So primary means what? Primary means there is no cause. Secondary means it is due to a systemic cause. And congenital means obviously congenital, nothing doing. Can you give me an example of primary disease? Can you give me an example of primary nephrotic syndrome? Yes, minimal chain disease, FSGS, membranous glomerulonephritis. Can you give me a cause of secondary nephrotic syndrome? Yes, diabetes mellitus, and your favorite, my favorite, the disease which was synonymous to me as rheumatology. When I was in MBBS, I used to think rheumatology is equal to SLE and SLE equal to malar rash. This was my entire knowledge when I was in third year of, because I was not as intelligent as you all. So I used to think this to me, and it is only when I started doing my MD medicine and I saw I was fortunate enough to be working in one of the best rheumatological departments, and I got to see numerous hundreds of SLE patients. Then did I come to know that SLE has so many facets to it, and SLE is just not just what we think, malar rash. Okay, is it clear? Now what are the causes of congenital nephrotic syndrome? ये पढ़ाने के लिए मुझे आपको इतनी मेहनत करनी पड़ी मुझे. Okay, so congenital nephrotic syndromes are also known as familial podocytopathies, and you can understand why they are known as podocytopathies, because so the congenital nephrotic syndrome are known as familial because they are congenital, and podocytopathy because it is a pathy of podocytes, and you can understand where was podocyte located. And what are the examples of familial podocytopathies? Very good. Number 1, NPHS1, NPHS2. Number 3 can be what? Wilms tumor 1 gene. And there can be many. Itna hi bahut hai. And this, as you correctly said, this is Finnish type. Correct. Absolutely correct. This is also a question. So these are the causes of congenital nephrotic syndrome. I hope I'm absolutely clear. Okay? And now let me quickly enter into the next. And now let us enter and discuss the nephrotic syndromes in detail. And what we shall do is, you must have heard ek tir se do nishane. I am trying to mean 2 targets by 1 arrow. But we will try something adventurous today. We will try ek tir se 3 nishane. So 3 targets with 1 arrow. And I am not Rajnikant sir. With all the due respect to the people who love them, so do I. He does that. He can do anything. He can split a bullet into 3. He can split an arrow into 3. But I am just a very humble person. I will try to do so. Okay. Thank you. Okay. So now please take a fresh page, all of you. Fresh page, and divide your page into minimal change disease, FSGS, and membranous glomerulonephritis. Divide your page into these 3. Okay? And now let us start discussing each one of them. Make 3 columns. So let us say age. You know that MCD is a disease of children. FSGS is more commonly found in adults. And dekho, if you have to go with the flow, children, adults, where do you think membranous is commonly found in? Where do you think? Obviously, it is elderly. It is elderly. Is it clear? So, children, adults, elderly, nothing doing. No, nothing to memorize. Just go with the flow. Now, come to causes. Come to causes. If I ask you, what are the causes? What is the primary cause of MCD? Sir, it's a rhetorical question. Had there been any cause, it would not have been primary. It would have been secondary. So, primary cause is idiopathic. 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 The primary cause of all the three are idiopathic. Is it clear? Absolutely clear. Very good. Very good. Coming to the secondary cause. Coming to the secondary cause, let us discuss one by one. First, drugs. First, drugs. What are the drugs that cause MCD? So just listen to this story. Just listen to this story. You know, children are very naughty, and you know they always want to play in the dirt. If they play in the dirt, their clothes will get dirty. When their clothes will get dirty, they will come to their mother, and their mother will give them a bump at L. And ultimately, after giving them an L, mother will have to wash their clothes with this, and will give them an L. L, I know. Those who have got it, they can understand what is it. Clear? So, what are the drugs that cause MCD? Are rifampicin, interferon, NSAIDs, and lithium. The drugs causing are Rin-L, rifampicin, interferon, NSAIDs, and lithium. Coming to membranous, FSGS. FSGS is a very, very naughty character. It's a very dirty character, and whenever you see it, it is looking at you with a very smirk, and you are bound to ask it, "Beta FSGS, why are you so happy? Why are you so happy?" So there are three reasons of being happy. Number one, something to उसने कुछ लिया. It has taken something. And while it has taken something, it has got into a mess and contracted an infection. And while it has been done so much damage to itself, it will cause a lot of damage to the person also. So FSGS is happy, happy due to three reasons. And I will tell you one by one. I told you it has taken something. What has it taken? It has taken this. It can be associated with this also, analgesic, and P for pamidronate. The next two reasons of happy I'll tell you gradually. So the drugs associated with FSGS are heroin, analgesic, and pamidronate. And the drugs associated with membranous, membranous is common in which group? Elderly. And you know, if you have ever opened the almirah of an elderly person, the grandmother or your maternal grandmother at your home, you will see they have a lot of this in their cupboard stored. Lot of this. And of course, they are usually hypertensive. So to measure the blood pressure, they also have an instrument which contains this mercury. And most of them, because they are hypertensive, they take a drug which is of this class, which is an ACE inhibitor, like a captopril. Yes or no? Yes or no? Or elderly are usually hyperuricemic, so they also take this drug, proben acid, which is the uricosuric drug. And last drug, likh lo, not fitting in the story. So just write down like this. So the drugs that can cause membranous are gold, mercury, captopril, proben acid, D-penicillamine. I hope it is clear to you. Many of you are thinking, sir, why are you telling me so many drugs, sir? What use, sir? Because asked. All these questions have already been asked. And there are more drugs also. But I have given you the very important drugs which have been asked or which will be asked. So these are the drugs that cause MCD, FSGS and membranous. What is the next cause of next secondary cause that we will study? Let us study infection. Let us study infection. The infection associated with MCD, nothing. The infection associated with I told you it is happy due to 3 reasons. Ek to usne, he has taken heroin, and while taking heroin, he has contracted this disease. So HIV, very important, associated with which glomerular disease? Answer is FSGS. And what disease is which infection associated with membranous? Hepatitis B, hepatitis C, syphilis, also tuberculosis. Clear? And a pathological question, let me answer you. There are many types, microscopic types of FSGS taught in your pathology. Which type of FSGS is associated with HIV? It is collapsing type of FSGS is associated with HIV. Is it clear? And of course, that which is associated with HIV will have worst prognosis. That goes without saying. Is it clear? Absolutely clear to all of you? Very good. So these are the infections. After infections, what can be associated? What neoplasms can be associated with all the three? With MCD, you have Hodgkin's lymphoma. With FSGS, you have non-Hodgkin's lymphoma. And with membranous, you have 2 cancers above the diaphragm and 2 cancers below the diaphragm. The above ones are CA breast, CA lung, and below are CA colon, CA kidney. And this was asked very recently, that CA breast and colon are associated with which glomerular disease? Answer is membranous. So Hodgkin's, non-Hodgkin's, 2 above diaphragm, 2 below diaphragm. These are the 4 cancers associated with membranous. Next, what are the miscellaneous causes? Thankfully, no miscellaneous cause for MCD. No important miscellaneous cause for MCD. Which miscellaneous cause for FSGS? Which is the miscellaneous cause for FSGS? Very important, sir. A, hypertension. B, I also have to worry about it. Obesity. C, familial podocytopathy. D, Fabry's disease. Yes, we are back. We are back. I hope you can hear me now. Yes. So the miscellaneous causes of Fabry's are hypertension, obesity, of FSGS, familial podocytopathy. I hope you remember the examples. Fabry's disease. This was a very recent MCQ. Fabry's disease causes secondary dash. Answer FSGS. And because the name is focal segmental glomerulosclerosis, so some sclerosing diseases, like what are the sclerosing diseases that are associated? What these are the miscellaneous causes. Please understand, we did the neoplasms and we had Hodgkin's, non-Hodgkin's, breast, lung, colon, kidney. Now we are discussing the miscellaneous causes. Nothing for MCD, hypertension, obesity, familial podocytopathy, Fabry's disease and sclerosing diseases. Okay? I hope I'm absolutely clear. And sclerosing diseases, what do you mean by sclerosing diseases where there is sclerosis? And what are the sclerosing diseases you know of? There can be sickle cell anemia. There could be reflux nephropathy, etc. So these are the sclerosing diseases that can cause FSGS. And which is the miscellaneous cause? Which is the miscellaneous cause of membranous? Is Madam SLE. Madam SLE. And I hope you remember, why am I calling SLE as madam? No, I am not a sexist. Though I genuinely support females, I do not want to, I'm not basically doing that for favoring any gender, because SLE is a disease of females. And the female to male ratio is 9:1. And the words of my mentor, that SLE ka female to male ratio is 9:1. This even the group, the staff of the rheumatology ward knows. Okay? So there is absolutely no reason for you to not know that SLE is common in females. Absolutely clear. Okay? So the miscellaneous cause of membranous is MAM SLE, and I hope you have already studied the ISN RPS classification of SLE, of lupus nephritis, and you know that class 5 of lupus nephritis is membranous glomerulonephritis. I hope you remember that. Class 5. Clear? Absolutely clear? Very good. After the miscellaneous causes, now very quickly, let us understand the most important complication. Now, the most important complication of MCD is, so a mother of MCD, mother of an MCD patient came to me. She was very worried, hyper anxious, sir, what will happen to my son, sir? He's always swollen, sir, he's like this, you give him steroid, he gets okay. And so I told her, ma'am, please do not worry. There are approximately 95% chances that your child will get okay. And next day, she came to me with a box of sweets. When she came to me with a box of sweets, I took the box of sweets, gently pushed it into my drawer, and after putting it into a drawer, ma'am, please do not ask me to return the sweets to you. She was like, why, ma'am? Why, sir? I was like, ma'am, there are 95% chances that your child will be okay, but ma'am, there are approximately 75% chances that you will come back to me because the very important complication of MCD is a high relapse rate. So minimal change disease has a very high relapse rate. FSGS, I told you, naughty child, very, very naughty boy. 3 things. It took heroin, contracted HIV, and why was it laughing? Because there is a high risk of progression to CKD. High risk of progression to end stage renal disease. So जो आज का FSGS है, today's FSGS will be probably standing after a few years outside the transplant clinic because he will have end stage renal disease and will ultimately warrant a transplant. And the most important complication of membranous is thromboembolic complications. So this patient can have deep vein thrombosis, can have pulmonary embolism or renal vein thrombosis. Renal vein thrombosis. Is it clear? Thromboembolic complications, but write down a question mark. So you know, a question had come in last year's USMLE entrance exam, USMLE, United States Medical License Examination. Some of you might be preparing for it also. It was a 1-page question. You know, they give very long, hefty histories. So a man residing in United States of America, 60-year-old man, he was a smoker, blah, blah, blah. He developed anasarca, urinary showed 3+ protein, 24-hour urinary protein showed 6 grams, serum complement was normal, antibody was this, biopsy showed this. One fine day, he developed a unilateral painful swelling of the right lower limb. 2 days later, he was admitted in the ICU of a hospital with acute onset chest pain and shortness of breath. And 1 day later, he died. Which disease did he have? You know what? I could have neglected the entire history. The last 2 lines says what? The man had acute unilateral painful swelling of the right leg. Basically, it was a deep vein thrombus, which ultimately embolized to have a pulmonary embolism, chest pain, shortness of breath. He died. So basically, he had a DVT and PE. Without even reading the biopsy finding and all that jazz, I know glomerular disease plus thromboembolism is equal to membranous. Simple mathematics. So we can apply maths in nephrology also. Just write down anywhere in your copy, DVT plus glomerular disease is equal to membranous. No need to read everything. Clear? So this is the significance of this point. Clear? Next, how do you investigate them? You can investigate them by looking for proteinuria, hematuria, C3, C4 levels, antibody. Absolutely clear? DVT plus pulmonary embolism I said. Now, I told you MCD is very, very selective like girls. It has only selective proteinuria. Whereas FSGS and membranous are non-selective. So they will have albumin also and other non-albuminic proteins also. Hematuria is never seen in MCD, but it can be seen in membranous, can be seen in FSGS. Now, you know, another thing that will keep troubling you in nephrology is complements. And I know your concept of complements in neurology is awesome. No pun intended. So is mine care. I also need to brush up really. Here, coming to complement C3, C4. So let me give you a dictum. You know, you'll be learning that इसमें C3 कम है, इसमें C4 less, C4 normal, C4 high, C3 high, whatever. Let me give you a dictum. In all three primary nephrotic glomerular diseases, C3, C4 is normal. So complements are absolutely normal. So your life is saved now. Absolutely clear. Coming to antibody. There is no antibody in MCD, no antibody in FSGS, but is there an antibody in membranous? Yes, sir, there is. Number 1. Anti-PLA2R antibody, and number 2, anti-THS-D1-7A antibody. So there are 2 antibodies. One is against phospholipase A2 receptor, and one is thrombospondin type 1 containing 7A domain. Just remember the short forms. ठीक है? One is PLA2R, one is THS D17A. So PLA2R is approximately seen in 70 to 80% cases. And sir, any other important, sir? Yes, beta. It is associated with poor response to treatment. Very good. So, anti-PLA2R is associated with 70 to 80% of membranous glomerulonephritis. And if PLA2R is present, patient को क्या बोलोगे? Good news? No, sir. Bad news, sir, because you are less likely to respond to treatment. And the next is thrombospondin type 1 containing 7A domain. That is seen in approximately 5 to 10% cases. So there are 2 antibodies, sir. Only 2, sir. और भी होती हैं, sir. बेटा और भी होती हैं. But if you remember these 2, this life can easily be passed. If you want to learn more, you can learn it from the club. I had given a post also. There are 5 types of antibodies that can be found, but not that important. This is more than enough. Is it clear? Very good. And this is a very important MCQ. Very important MCQ. Clear? So we have investigated them in details. And last but not the least, sir, I want a gold standard investigation. And I told you that the best thing to investigate anything is see it yourself under the microscope. So let me have a look at it by biopsying it. Clear? So what will I get in light microscopy? What will I get in electron microscopy? And what will I get in immunofluorescent microscope? Let us, you know everything. You know absolutely everything. So just jot it down for me. In light microscopy MCD, I will get no change. I will absolutely see it to be normal. That is why it is known as nil lesion. It is known as nil lesion. In FSGS, as the name says, I will get focal and segmental hyalinosis, the pathologic term for sclerosis. And what will I get in membranous? I will get thickened glomerular basement membrane. I will get thickened GBM. What will I get in electron microscopy of MCD? I will get effacement of food process. What will I get in FSGS? Here also I will get effacement of food process. And last but not the least, what I shall get in membranous? So basically, दूर से देखा तो GBM was thick. पास जाके देखा तो actually GBM had deposits below it. That is why it was appearing thick from a distance. So you will get sub-epithelial deposits. I will get sub-epithelial deposits. And last but not the least, what will I get in immunofluorescent microscope? In MCD, I will get no deposits. In FSDS, I will get focal IgM and C3 deposits. And in membranous, I will get granular IgG and C3 deposits. So, with this, we now know how will all the three glomerular lesions will look to me. Yes or no? So just remember two terminology which can confuse you. याद रखना, यहाँ पे it is focal, F for focal, F for FSDS, and यहाँ पे it is granular. और याद रखना, FSDS is a disease of adults and membranous is a disease of elderly, in which among antibodies IgM and IgG, which antibody stays for long? IgG. That's an older antibody. An older antibody will be found in oldies. So IgG, membranous, old. IgM, young. Some people are saying, sir, why C3 normal? C3 is normal because it gets deposited but not in that much amount that can deplete the serum C3. Absolutely correct question. Correct question. It is not low because it is not deposited in huge amounts like immune complex diseases. Okay? Because there are no immune complexes floating in the serum. It is just deposited in the organ only. Good. Clear? Absolutely clear. Very good. And now what we shall do is, now we shall try to draw the diagram, we shall try to draw the biopsy figure by our own abstract imagination with a schematic diagram. You know this, please try to draw this on my own. This is your endothelium, this is your GBM, this is your mesangial cell, and I told you this is how a normal food process of podocyte looked, but in membranous you will have effacement of food process, so there will be food process flattening. Food process flattening, just see. So this was a normal food process of podocyte. This is a normal. And this is effaced. So this will be found in MCD and a similar picture will be found in FSGS. Clear? What will you get in membranous? Draw on your own. This is endothelium, this is your GBM, this is your food process which will be normal here. Yes, and try to draw it on your own. What will you have? Sub-epithelial deposits. So sir, I will have deposits in the below the epithelium. So it will look something like this. So now, if you can take this photograph home with you, how it is looking, so you have to never mug it up. और आप भूलोगे नहीं कहां पे क्या डिपॉजिट है, because you have drawn it, you have picturized it yourself. This is the way to learn medicine. I hope I'm absolutely clear to all of you. Clear? Absolutely clear. So last but not the least, sir, सब कुछ कर लिया, how will we treat it? How will we treat it? To treat this MCD, we will give the patient steroid. We will give the patient steroid. This is of course the best treatment for MCD. Clear? Clear? If the patient becomes resistant or there are frequent relapses, so you have to add a steroid sparing agent. So if there are frequent relapses, you usually add cyclophosphamide, and if the patient is resistant, you add calcineurin inhibitor, that is CNI, steroid sparing agents. Clear? What about FSGS? Sir, just like any proteinuric condition, first we will give the patient ACE inhibitors, ARB. Second, we will give the patient steroid. If steroids don't work, what will you give the patient? You will add immunosuppressive therapy, usually CNI. And how do you treat membranous? Sir, of course, again you will give the patient ACE inhibitor, ARB. Number 2, you will give statins to the patient. Sir, why statins? Tell me, I am expecting the answer. Why will you give statins? Next, you will give the patient steroid plus immunosuppressive therapy. If this does not work, then you will give the patient rituximab, which is the monoclonal antibody against CD20. And if this also does not work, to your surprise, you will give the patient synthetic ACTH. And you know, that which surprises you is frequently asked in the exams. Statins are given because, if you remember, most common thromboembolic complications occur in, membranous, plus membranous are elderly also. So they require statins and they are the highest risk of developing thromboembolism. Very good. So this is how you treat them. Now please understand this. देखो treatment में difference, please see that. Here you first give steroids. If they don't work, then you give IST. But here you straight away give steroids plus IST. Is it clear? With this, we have completed all the 3 types of primary nephrotic syndromes. CNI means calcineurin inhibitors. Clear? IST means immunosuppressive therapy. I hope it is absolutely clear to all of you. I hope you are all enjoying. Arrow means if this does not work, then this. If this does not work, then this. Clear? No, beta. I still have 15 minutes more. I will take those 15 minutes of yours. Please bear with me. I hope you want to do the class. Yes or no? Quick, give me replies. Give me a reply. Good. Very good. Come on, beta. If you have to achieve things, you have to work hard. वर्क हार्ड. सम पीपल आर सेइंग सर मोटिवेशन चाहिए. सर चलो मोटिवेशन के लिए एक चीज देता हूं. मोटिवेशन के लिए लेट मी गिव यू समथिंग. मोटिवेशन के लिए देता हूं वन चीज. प्लीज अंडरस्टैंड, इफ द प्लान डज नॉट वर्क, चेंज द प्लान बट नेवर द गोल. सो आवर गोल इज टू गेट अ पीजी सीट. So much is at stake for the PG seat, you know. If you work for the next 6 months hard, it can take you 50 years ahead in life. I do not want a person who's passionate about doing medicine and maybe nephrology to end up with an anatomy or a pharmacology. I wish not it might happen. But please, please and please, you have to be enthusiastic with me. I will take some more time of yours. Clear? Good. So now we have completed nephrotic syndrome. We have completed nephrotic syndrome, and now we shall enter into nephritic syndrome. Okay? We shall enter into nephritic syndrome. Good. That's the student, that's the spirit, my students. I expected this only from you. I expected this from you. Good. So nephritic syndrome is characterized by number 1, proteinuria, number 2, edema, number 3, hypertension, number 4, hematuria, and number 5, renal failure. Why is any better? I'll tell you in the end. Just remember, this was present in nephrotic also. This was present partially in nephrotic because that was anaphylaka, this is edema, mind you. But these three are absolutely new and they are not present in nephrotic syndrome. So these are absolutely new points. Hypertension, hematuria and renal failure. Clear? Very good. I hope you want me to complete your syllabus. Yes or no? If you want, please cooperate with me. Clear? If anybody is feeling hungry, munch something while doing the class. Clear? Some people are comparing me to, Yuki, ye kaun bola? Yuki, I don't have a habit of speaking much, but I tend to speak here. Joke is not working clearly. Chalo, classification of nephritic syndrome or glomerulonephritis. So the classification of glomerulonephritis or nephritic syndrome is, you divide them into 3. Number 1, antibody mediated. Number 2, immune complex mediated. And number 3, pauci-immune. And what do you mean by pauci? Pauci means less or without. Pauci means less or without. So what is the example? What is the example or causes of all the 3? So antibody mediated are number 1, anti-GBM disease. Number 2, good Pasteur disease. anti-GVM disease and good Pasteur disease are antibody mediated glomerulonephritis. Immune complex glomerulonephritis can be further divided into A with low C3 and B with normal C3. So immune complex mediated with low C3 के examples हैं नंबर 1 post streptococcal glomerulonephritis and नंबर 2 आपका और हमारा फेवरेट lupus nephritis, नंबर 3 cryoglobulinemia and number 4 subacute bacterial endocarditis. Subacute bacterial endocarditis. Immune complex mediated with normal complement के examples हैं नंबर 1 IgA nephropathy, number B IgA vasculitis, which I think many of you know by this name, but I think you know that Henoch-Schönlein purpura has been now retermed as IgA vasculitis. Coming to posse immune. So posse immune ने basically antibody immune complex वाले ने posse immune को बोला, immune complex mediated GN said to posse immune, I have immune complex, I have C3, what do you have? And posse immune in a very very filmy and dramatic tone said, तो क्या हुआ अगर तुम्हारे पास immune complex है? So what happened if you have immune complex? मेरे पास ANCA है, I have ANCA. Clear? So posse immune GN are basically the ANCA positive GN. And I think you know that ANCA G positive GN names, they are number 1. Thankfully you have already had the rheumatology class. Number 1 granulomatosis polyangiitis, number 2 eosinophilic granulomatosis polyangiitis, number 3 microscopic polyangiitis. You know GPA is basically the new term for Wegener's. eGPA is a new term for Church-Strauss syndrome, and microscopic polyangiitis, you know, is basically the third p-ANCA positive small vessel vasculitis. Clear? Absolutely clear. Very good. And we still have 6 minutes. We will utilize it very quickly. Okay? Subacute bacterial endocarditis. And the last topic of the day, last 6 minutes of the day, let us quickly utilize to study two important glomerular diseases. Let us study post-streptococcal glomerulonephritis and IgA nephropathy. Always, you know, we have a habit of एक तीर से दो निशाने. So let us compare them quickly and let us finish them off very quickly. Very good. Chalo. Very good. You must know IgA nephropathy is also known as Berger's disease, and it is the most common primary glomerulonephritis. It is the most common primary glomerulonephritis in the world. In the world. Clear? बेटा मेस बंद हो जाएगा, स्विगी कर लेना. Okay, IgA nephropathy is Berger's disease or most common primary glomerulonephritis in the world. Very quickly, very simple, you know, no need to mug up. Just you will tell me the answers. You will tell me the answers. I will not say. Very intelligent students. Age. You know, post-streptococcal glomerulonephritis occurs in 5 to 14 years. age group. IgA nephropathy, young adults and adolescents, 10 to 13 years. Very simple. Very simple. You are only saying, I am not saying. Number 2, predisposing factor is what? Streptococcal infection. Streptococcal infection. Predisposing factor for IgA nephropathy is upper respiratory tract infection. Upper respiratory tract infection. Clear hai? Absolutely clear hai? Now, very important, please listen here. Streptococcal infection आज होगा. After streptococcal infection occurs, 2 to 6 weeks later, the patient will have hematuria. Because symptoms are common. I told you 5 symptoms of nephritic syndrome. I hope all of you remember that. Very intelligent students of mine. Very good. Now, in IgA nephropathy, today infection occurred. 1 to 2 days later, patient will have hematuria. I am repeating. Today sore throat, 15, 20, 25, 30 days later hematuria or nephritic syndrome, PSGN. Today sore throat, tomorrow red urine, IgA nephropathy. Because IgA nephropathy and pharyngitis almost appear simultaneously in IgA nephropathy. This is known as synpharyngitic hematuria. But here the gap between the pharyngitis and hematuria is delayed. That is known as delayed hematuria. And this is a very important MCQ. So many clinical scenarios can be formed. In fact, in my MRCP part 1 exam, there were 2 questions based on the same thing. So you understood. Don't need any biopsy finding, any complement levels. Very simple. Today sore throat, tomorrow hematuria equals IgA. Today sore throat, whatever be the rest of the things, 10, 15, 20, 30 days later hematuria, answer is PSGN. So simple. So simple. Clear? How will you investigate this? How will I investigate this? Quickly tell me. If I do a complement level, I can do a ASO titer. Yes, I can do a serum IgA levels. And last but not the least, I can do a biopsy. That is a gold standard. So if I do a complement level, I hope you can remember PSGN was in that group, immune complex with low C3. So I will get low C3, normal C4. But IgA nephropathy was in the group immune complex with normal C3. So I will get normal C3, normal C4. So the clinching point here is low C3. So till now I have whatever diseases I have taught you, there is only one disease which has a low complement C3 level. Is it clear to all of you? Coming to ASO titer. ASO titer is elevated in PSGN. It is normal in IgA nephropathy. Serum IgA level is normal here, but in IgA nephropathy, it is elevated. But tell me one thing, is IgA level high the diagnostic test of IgA nephropathy? Absolutely not. That is only present in 1/3 cases. So there will be still 66% cases of IgA nephropathy where you will not get a high serum IgA. So serum IgA, getting a serum IgA done is not a diagnostic test. It can only lead you towards it. I never order it. Clear? Is it clear? Absolutely clear. Yes, I am finishing it. I am finishing it. I am finishing it. Last but not the least, what will I get in the biopsy? You already know that. You already know that. I will get lumpy, bumpy, subendothelial and subepithelial deposits. This is the term used for Robbins, from Robbins. And what will I get in IgA nephropathy? IgA nephropathy mein what will I get? I will get number 1, mesangial hypercellularity, and number B, mesangial deposits of IgA and C3. Again you will ask me, sir, if C3 is getting deposited, why is C3 normal? Again my same answer. Why my same answer? Clear? Clear? So now, without seeing the screen, please tell me how will they look like? Draw a schematic diagram for me. Nothing big. You know the answer already. Please try to visualize it for me. These are the 3 layers. How will it look like? Sir, यहाँ पे mesangial cell बना दो 2. यहाँ पे there is mesangial hypercellularity. So I have made this. This is the mesangial hypercellularity. And yes, sir, deposits will be here. Subendothelial and subepithelial, more in the subendothelial. Whereas here, there will be mesangial deposits and mesangial hypercellularity. So simple, sir. Such an easy drawing. And sir, if I can make this on my own by the end of this class and I can remember the photograph, sir, no need to remember all these deposits, everything. You can have a picturesque memory, which is what matters. Clear? Absolutely clear? Clear? Yes. Thank you. And last sentence is, how do you treat each one of them? The treatment of PSGN is, of course, as you all know, steroids. Yes? Correct answer? Absolutely wrong answer, sir. This is wrong. Please write it and mark it wrong. Please mark it wrong. This is not the treatment because you only give supportive therapy. Sir, what do you mean by supportive therapy, sir? Sir, fever है तो paracetamol दो. Sir, edema है तो diuretic दो. That's it. Only supportive treatment. There is no role of steroids in post-streptococcal glomerulonephritis. While in IgA nephropathy, you give number 1, ACE inhibitors plus ARB or ARB. You give for an antioxidant omega-3 fatty acids. You can give steroids. So you can give ACE inhibitors or ARB, you can give omega-3 fatty acids, you can give steroids also. Is it clear? And last but not the least, which is probably going to, raise a few eyebrows in some students, I know that very well. What is if you give this and the patient is not responding, what can you do then? What can you do then? You can also give, if the patient has, you can also do a tonsillectomy. You can also do a tonsillectomy, which has been propagated as one of the treatments for IgA nephropathy. Is it clear? Some people are saying, sir, why tonsillectomy? Why tonsillectomy? As an antioxidant. as an antioxidant. Clear? Or just to answer your queries, some said, if you have to tell me in one word, what is the pathogenesis of PSGN? In one word, it is molecular mimicry. And what is the pathogenesis of IgA nephropathy? It is defective galactosylation of IgA. Clear? And why? Because galactosylation of IgA happens in lymphoid organs, and tonsil is a lymphoid organ. That is why it might work. Is it clear? Absolutely clear to all of you. So we have so wonderfully, we have just compared PSGN and IgA nephropathy, and I think you can remember everything now. I hope you can remember everything now. Clear? With this, I would like to conclude today's class, and I would just like to show you one photograph. Please see this. Please see this. As I told you, there are 3 layers. This is the fenestrated endothelium. This is the GBM, and this is the foot process of podocytes. Please look here. This green color structure is your slit diaphragm. And see, this slit diaphragm is formed of nephrin. And when this nephrin will be mutated or lost, you will get a podocytopathy and you will get nephrotic syndrome, because all the proteins will leak from here. Is it clear? Absolutely clear. Okay, and just see, I told you GBM is, and see, endothelium is negatively charged. I told you GBM is made up of collagen 4 alpha 3 4 5 chains. It is made up of laminin 11 and agrin, which is a heparin sulfate proteoglycan. Okay, and this is the foot process of podocytes and the slit diaphragm. I hope it is absolutely clear. Now, can you please see this boy who has a periorbital edema? Young chap, nephrotic syndrome. Of course, this is a patient of minimal change disease with a periorbital edema. Clear? And the last slide for today. Yes, last means last. The very last. Please see, there are some horizontal band in the nail. There are some horizontal bands in the nails, and this is known as Muir canals. This is known as Muir canals, and this Muir canals is found in nephrotic syndrome. Sir, why? Due to hypoalbuminemia. This is Muir canals, and Muir canal is an MCQ. It is found in dash. It is found in nephrotic syndrome due to hypoalbuminemia. Hypoalbuminemia. Is it clear? Absolutely clear. Very good. Thank you for listening to me so patiently. I am very sorry I may have surpassed some minutes of yours, taken some precious time of your busy schedule, and I would like to end today's class with this note: if you can dream it, you can do it. But I do not mean only be a daydreamer. Those who have dreams, those dreams don't let you sleep. So please do not just be a daydreamer, but yes, dream big. If you can't dream big, you will never achieve big. So it's always said, hitch at the sun, so that even if you fail, you will land up on the moon. So dream big, yeah. Don't think small. Just don't think, sir, bas ek MD seat mil jaye. Not at all. Only target central institutes. Target rank 1 of AIMS. Only target the best. Is it clear? Absolutely clear. Thank you so much. These are my contact details. Okay, I am there available on all social platforms except Instagram. So mail ID, my YouTube channel, my page, my Twitter account, and you can find all my Dams Club posts with the hashtag Vivek Medicine Goyal. This is my hashtag in our Dams Club. Okay, I shall start a thread also. I hope. Please give me a thumbs up if you enjoyed today's class. Give me a thumbs up if you enjoyed today's class. I really enjoyed thoroughly teaching you. I am also feeling hungry, I know. You are also feeling hungry. And we will all conquer it together. I am with you together always. Please forgive me if I have not answered one query of yours. Please forgive me. I will answer everything. I will answer everything. I am there for you always for medical or for any issue that you have. And kudos to you. See you tomorrow with a lot of enthusiasm. I see a few thumbs. I see a lot of thumbs up. Thank you so much. Thank you so much. And I know I'm very sorry if I have surpassed some time or minutes of yours. Keep revising. Stay foolish. Stay hungry. Love you all. Thank you so much. Good night. Shabba khair. Thank you.